Hi, everyone. Good afternoon. My name is Madeline Sterling, and I'm delighted to chair this session, Elevating Home Care Work, Interdisciplinary Perspectives and Policy Implications. Today, we're going to hear from 4 different speakers, which span our campus of Cornell University in Ithaca, Weill Cornell Medicine in New York City, and the Cornell Tech campus in New York City. The 4 speakers will present on various aspects of home care and the home health aide workforce. The first presentation will be by Johnny Kallas, a PhD candidate at Cornell University's ILR school, titled Making a Bad Situation Worse, Examining the Challenges Facing Rural Home Care Workers. Johnny is a 4th-year PhD candidate at Cornell's ILR school. His research focuses on labor relations, organizing, and strikes across the United States, with a particular focus on healthcare workers. He also serves as a project director for the ILR Labor Action Tracker. Next, we'll be hearing from Joy Ming from Cornell University's Cornell Tech campus, her talk titled, I Go Beyond and Beyond, Examining the Invisible Work of Home Health Aides to Design Appropriate and Equitable Technology. Joy is starting her 3rd year of her PhD at Cornell Tech in Information Science. Her research interests are care, the future of work, and global health equity and design justice. She is currently working with home health aides in New York City and ASHAs in Asia to design technology that helps improve their working conditions. After that, we'll hear from Anthony Poon, a newly minted PhD from Information Science at Cornell University. His talk will be on sharing circles for intersectional peer support with home care workers. This is a peer support intervention. His research focuses on designing and evaluating computer-mediated programs that address the support and empowerment needs of physically isolated and marginalized practitioners. Currently, he works with home care workers in New York City and aims to connect critical and emancipatory perspectives to workers' everyday experiences. And finally, we'll hear from Dr. Mara Bensson, a physician researcher at Weill Cornell in New York City. The title of her talk is The Association Between Voice, Burnout, and Job Satisfaction Among Home Health Aides, Findings from a New York City Survey. Mara is completing her residency in internal medicine and primary care at Weill Cornell New York Presbyterian Hospital, and she's looking forward to a career in primary care and medical education, and will be joining Massachusetts General Hospital and Harvard in the fall as a general internist. A few ground rules. Each speaker will give their talk for 10 minutes. I'll be giving them a 2-minute warning before their allotted session is up. And we'll actually hold questions until the end. So I encourage the audience members to put their questions in the chat box. At the end, Professor Ariel Avgar of Cornell University's ILR School will make a few remarks about uniting the themes across the 4 talks, and then we'll move into questions. If you can, please mute yourselves while we're speaking. And again, we encourage the chat box use. And without further ado, let's hear from Johnny Kallas.
Great. Thanks so much, Maddie, for that introduction. I'm assuming you all can see this, hopefully. Okay, so I'm working on the following project, which focuses on rural home care delivery and specifically rural home care workers, direct care workers who provide a range of tasks to many clients on a daily basis and are obviously an essential component to home care delivery. Thanks as well to Maddie, Ariel, and Dell for their support throughout this project. Okay, so as some of us know, the U.S. home care system is confronting a considerable care gap as the population ages and more people want to age at home. The demand for home care services continues to outpace the number of home care workers, as nearly 7 million direct care workforce jobs will need to be filled by 2028. This care gap is especially pronounced in more rural areas. So senior citizens are expected to comprise about 28% of the rural population by the end of the decade, compared to 20% in urban and suburban areas. We know that people who live in rural areas experience worse health outcomes and have less access to healthcare services, including less utilization of home care services, and the trend of nursing home closures and mergers in rural areas place an even greater burden on the home care delivery system. So to confront this worsening care gap and to identify opportunities for improvement in rural settings, we need to understand the challenges facing home care workers. And we can really think of 2 types of challenges for the purposes of this study: universal challenges that confront all workers, such as low compensation, and challenges confronting rural caregivers specifically. We also need to understand how universal challenges compound unique challenges and vice versa. While an increasing amount of research has begun to examine these universal challenges, generally through studies of workers in more urban areas, the minimal research on rural caregivers often focuses on specific issues like turnover, rather than categorizing these broader challenges. So we very much argue that we need to understand and categorize these broader challenges facing rural home care workers to determine how to best support these workers and confront the growing care gap. And we aim to do this through this study by directly talking to these workers about their experiences. So we began our research study through outreach to multiple types of home health organizations, including unions and other labor organizations, home care agencies, and local long-term care committees. These organizations then helped connect us with potential interviewees and provided us with a general understanding of the challenges facing the long-term care system in more rural parts of upstate New York. Because of the limited research on the challenges facing rural home care workers, we decided to complete a qualitative study to begin understanding and classifying these sets of unique challenges. So we undertook an interview-based study from July 2021 through February of this year. And for the purposes of this study, we did define rural quite broadly as really any place that isn't a major city, such as Syracuse, Buffalo, Rochester, or Binghamton, or an immediate suburb of that city. So we ended up recruiting participants from more rural areas of Erie and Onondaga counties, and also the most remote parts of the North Country or the Adirondacks. So we conducted 23 interviews, which consisted of 19 home care workers, 2 home care agency representatives, and 2 long-term care policy advocates. Participant characteristics are on your screen in front of you. For the sake of time, I'm going to keep moving forward, but can come back to this slide during the Q&A. And we really identified 4 main themes that correspond to the types of challenges confronting rural home care workers from our interviews. So the first 3 are unique challenges confronting rural home care workers. Number 1, transportation and infrastructure challenges. Number 2, workforce and workflow issues. And 3, patient social isolation and defiance. And then the final theme we identified really discusses how more common or universal challenges confronting the home care profession exacerbate the unique challenges identified above, and vice versa. Okay, so to dig into these specific challenges, the most common challenge addressed by rural home care workers in our study regarded transportation. So workers put a considerable amount of miles on their vehicles and need to have reliable transportation when dealing with the upstate New York climate, especially in the winter. One caregiver reported traveling approximately 800 miles a week due to having multiple clients a day at only 1 to 2 hours a day per client. The average travel time between clients in the Adirondacks region, for example, is approximately 30 minutes. So difficulties really associated with commuting to and from clients' houses came up repeatedly throughout interviews. And then low quality infrastructure also impacted the daily tasks of many caregivers. So rural regions are more likely to be impoverished, and multiple aides discussed clients they had who lacked, for example, adequate running water. As the quote here indicates, the lack of basic necessities really impacts how often a client, for example, could get properly bathed. So the second theme we identified includes workforce and workflow challenges, largely due to the shortage of caregivers in rural areas, already briefly mentioned. So many aides identified increased compensation as a way to attract more workers into the field. An agency representative we spoke with discussed how they would like to increase pay, but the reimbursement scheme is set up in a way to inadequately compensate agencies for travel time between cases, when agencies still pay caregivers, but are not being reimbursed at the same rate at that time. And with travel times of approximately 30 minutes between each case multiple times a day, this obviously has profound implications on pay and compensation for both agencies and eventually caregivers. We also noticed that aides overwhelmingly work shorter cases, defined as 1 or 2 hours in rural areas. Future research will need to determine if this is unique to rural areas more broadly, but it clearly impacts the type and extent of care that home care workers may provide. The third theme we identified involves patient social isolation and defiance. So living in a particularly remote area may prevent any interaction with the outside world, as evident in the first quote here. This physical isolation may also lead aides to feel more lonely and isolated on the job, though we need more research to determine that. And then the attitudes of rural residents may also lead them to resist care. Just to read out one of these 2 quotes at the bottom, quote, "It's more farming, more farm towns. They're used to living or doing things with less. I've had people that never took a bath before. They wouldn't shower, they'd only bathe," close quote. And we try and argue that these attitudes really impact the daily work of many caregivers with rural clients. So the final theme describes how universal problems confronting the home care profession exacerbate the unique challenges mentioned before and vice versa. So low compensation clearly impacts both transportation challenges and the persistent labor shortage in rural areas. These two quotes really highlight the impact that low compensation has on rural caregivers. And then similarly, transportation challenges in rural areas may exacerbate issues like unrecognized emotional labor. So as one participant explained, quote, "I went and spent the night with her a couple of times when I knew we were going to have a severe storm the next day because there was nobody to get her to her house. There was nobody to get to her house, excuse me. So I did go spend the night with her. I slept on the couch and we had a slumber party. I did that on my own. I didn't get paid for those times, but I get to know my peeps and I love them," close quote. So this caregiver worked as many as 12 unpaid hours to make sure her client received care during inclement weather, which, as most, if not all of us know, is quite common in upstate New York for half the year. So how do we think about policy change given these findings? We want to first emphasize that regardless of specific policy solutions, we really need policy awareness that these issues, such as transportation and infrastructure investments, need to be part of the conversation on how to address problems with our long-term care system. So an important first step, we would argue, is to encourage pilot programs to address obvious challenges through efforts such as a recent transportation pilot undertaken by Cornell University's Worker Institute and Healthcare Workers Rising in upstate New York, which is an organizing project of 1199 SEIU. So transportation was the most common challenge voiced by home care workers in our study. It's also a very logistical and technical challenge that should allow for creative solutions. The Cornell pilot provided fully subsidized rides for workers to reach clients using Lyft in multiple Western New York counties. Workers indicated that this program helped expand work opportunities and reduce job-related stress, and more pilots like this should very much be encouraged. And then finally, efforts to address quality of care concerns for rural patients need to account for the unique challenges associated with the delivery of home care. So for example, reimbursement systems need to account for geographic realities of care delivery in rural areas, such as by reimbursing agencies and workers for travel time between clients. State and federal policies need to address low compensation, inadequate funding, and invest in both urban and rural home care work. Really, the bottom line here is that policymakers need to address these challenges and shoulder some of the burden that right now is disproportionately impacting caregivers. And maybe I even finished ahead of time. Thank you all so much. I'm looking forward to your feedback in a little bit. And now I'll pass it over to Joy, I believe.
Great, thank you, Johnny. And remember, questions we'll do at the end. Next, we'll hear from Joy Ming.
Hi, my name is Joy. Let me get my presentation set up. All right. And so today I'm going to be talking a little bit about our research relating invisible work with the home care workers that Johnny was talking about. And so for this presentation, there's about 3 kind of major points. So the first is that home health aides are essential but vulnerable workers. And so they do a lot of essential work, but face a lot of challenges and vulnerabilities due to their identities as workers. The second piece is understanding this vulnerability through the idea of invisibility. And so looking at how the mechanisms of invisibility can lead to vulnerability and challenges, and also then lead to additional invisible work that is unpaid and unrecognized. And finally, the last point will be about technology intervention. And so how this understanding of invisible work, of invisibility and vulnerability can help us design technological solutions that can help the home health aides and help them rise above these vulnerabilities and these difficulties that they're facing at work. And so to start off with, home health aides do essential work, but are vulnerable workers. Johnny did a great job of introducing kind of the background of home health aides, and they are paid professional caregivers who give care to their clients in their homes, often for people who are looking for long-term care, who want to age in place. And they do 2 main areas of activities, as you can see through these lovely stock images. They do activities of daily living. So this could be things like having meals that are specified to the client's dietary needs, It could also include things like bathing and grooming and doing grocery shopping. And on the other hand, we also have clinical monitoring, which can include things like in the picture depicted, pill and medication reminders, but also things like taking vital signs, blood pressure monitoring, and temperature as well. And as we spoke about earlier, the home care workers are doing this essential work for patients as the number of people who are in need of long-term care is increasing greatly, but there is a decrease in the number of family and friend caregivers, and therefore there's this kind of impending care gap. However, even though home care workers are giving such essential work, they're also facing vulnerabilities, often due to challenges in their identities as mainly women and immigrants, as well as locations of their jobs in people's homes, as well as their clinical status as people who do healthcare work but aren't necessarily considered part of the medical staff. And oftentimes this results in these jobs being seen as what literature calls a job of last resort, with all of these different vulnerabilities that the home health aides are facing. And so in our research, we are able to find different ways that the mechanisms of invisibility can lead to these vulnerabilities and challenges that the home health aides face, and then in turn results in additional invisible work that the home health aides have to do in order to accommodate for these challenges. And so in previous literature, there are three main categories of invisible work that have been seen, so sociocultural, sociolegal, and sociospatial. And in our research, we also found that there is a fourth category of sociotechnical mechanisms of invisibility as well. So for sociocultural mechanisms of invisibility, we're looking at the question of who is a worker. And so oftentimes, a lot of the home health aides are women, and they're women of color, they're immigrants. And so they're often seen as what's called a non-person. And so they're doing work in the background, and they're not necessarily seen as respected or necessarily recognized for the work that they're doing. And so this leads to different vulnerabilities around discrimination due to racial and gender identity. And so oftentimes the workers will face offensive racist comments made by their clients. And this then leads to additional invisible work where the aides will have to then work with the clients in order to manage the emotions of the clients, while also on their own having the emotional burden of coping with these difficult interpersonal interactions with their clients. In the second area of sociolegal, we look at the question of what counts as work. And oftentimes this type of work that the home health aides are doing, this reproductive labor, is not necessarily counted as productive labor and is thus devalued. And so this leads to the home health aides facing the vulnerabilities of lacking the protections around their works and facing a lot of harassment, as I discussed earlier, but it also makes it unclear where their boundaries are for what type of work they're doing. And so oftentimes they're asked to do things that are outside of the boundaries of their care, and they're considered more like housekeepers or maids rather than home health aides. And so this results in the need for them to do additional invisible work where they have to assert and reassert their boundaries. And this is often difficult for our home health aides who are first starting on the job, because they themselves are often unsure of how to approach the situation, and they're instructed by their agencies to not to bother the patient, not to anger the patient, and to kind of just do as they're told. And the third area with sociospatial is the question of where work is done. And so this is especially difficult for home health aides because the work is done in home, which is a non-traditional workplace, as well as a workplace that is geographically distributed. And so this means that there is difficulty getting their conditions known to their supervisors and getting support. So it often becomes their word against their clients for their agencies or any other difficulties that they're facing. And so this results in a lot of invisible work on their end to have to handle things on their own and to do extra work to contact their supervisors and to resolve any issues that they're facing. And so these are all examples of the three known mechanisms of invisibility that are seen in literature. And finally, with our study, we looked at the fourth, which is socio-technical, which is understanding the types of tools that are being used. And so the main concern there is that a lot of the tools that the home health aides have to use are ill-fitting systems. There were systems that were not made with the home health aides' voices in mind, that are complicated and often end up doing things, or are often used to do things that aren't necessarily helpful for them in their work. So in this case, they have to do additional invisible work to spend extra energy learning how to use these systems. And oftentimes they're talking about how they have to wait for their children to be able to explain the systems or use the systems for them. They have to do extra work outside of their work time, because with the systems now, the clients are able to contact them whenever they want to. And so oftentimes they're contacted outside of their paid hours. And finally, they have to do additional work to figure things out on their own, because they have the access to Google and YouTube. Oftentimes they're Googling and YouTubing things of what they're supposed to be doing of how to do the things they're supposed to do at work. And so we have these 4 different mechanisms of invisibility as one way of understanding some of the vulnerabilities that the home health aides face and the invisible work that they do. And so the last piece is understanding how this can then translate into technology design and technology intervention. And so the idea is that technology intervention can help give aides the support, recognition, and respect that they deserve. And so that's something that came up a lot in the interviews, is the understanding that they want support, maybe through something like incident reporting or getting support from their peers in order to handle some of the challenges that they're facing, both logistically as well as emotionally. They want recognition for the work that they're doing and for all of the intrinsic knowledge that they're holding about their patient from spending so much time with them. And they also want respect and awareness for some of the difficulties that they're facing, so that they're able to get better treatment and conditions. And so the next step of the research is to then dive into this through focus groups. And so the focus groups would be on different ideas of different designs that can be used to as interventions for these different mechanisms of invisibility. And I'm working with the home health aides, but also contrasting their conditions with ASHAs in India to get a better sense of these global concerns that are facing workers who work in people's home doing home care and are often women in disadvantaged backgrounds. And but also understanding kind of like the local conditions of what each of the technological interventions might look like. And finally, the last piece is kind of understanding and balancing this idea of legitimacy and autonomy. So the idea of invisibility has led to a lot of difficulties and vulnerabilities, as I mentioned earlier through this presentation. But however, the solution isn't necessarily always just visibility, because that can also lead to restrictions in autonomy or surveillance in restricting the worker's ability to do some of the things, some of the intrinsic knowledge that they have, and some of the processes that are that they've developed. And so finding this balance between what is helpful to be visible and how to make these workers visible in a way that still helps them maintain autonomy. Right, thank you so much for listening to the presentation. And if you have any thoughts or ideas, feel free to mention them in the question session, but also to send me a message if you have any thoughts. Thank you so much.
Great, thank you, Joy. Next, we'll hear from Dr. Anthony Poon.
One second. So hello, everyone. Thank you for coming to the presentation. Today I'll be talking about some of the work that I presented with co-authors and collaborators and partners that we have in progress with home care workers in New York City. And this is around a program that we designed using sharing circles to address some of the support and empowerment needs of this group of workers. So I'm going to skip over the slides since Johnny and Joy did such a good job already of going over, one, the importance of the scope of home care work, Two, the fact that home care workers are a vulnerable workforce with multiple intersecting layers of marginality. And three, critically, the isolation of home care workers who must go to remote sites and thus have few opportunities to meet and build collective identity and interests, identify shared interests. So the goal of this research was to explore how to design a computer-mediated program to connect home care workers to their peers in a way that is oriented towards the diverse support needs of HCWs and towards empowering the community of HCWs to engage in political identity making and ideation. We discussed the main features of this program and how they were designed by insights from previous co-design studies that we did with home care workers, as well as foundational praxis in several liberation and decolonial scholarships. So the main feature of the support program was created around these narrative and reflective sharing circles. And these circles were minimally structured groups designed to create space for long form storytelling. This was inspired by Indigenous healing literature, where participants are encouraged to tell stories from their personal experiences rather than to give opinions. And in our program, sharing circles were held over video conferencing, and the affordances of this kind of computer-mediated environment, where, as you know, multiple people aren't allowed to speak legibly at the same time, can encourage this kind of turn taking. These circles also drew from similar methods in narrative and humanistic psychology, which use storytelling to encourage participants to recognize and reflect on the social and environmental aspects of their practice. And this reflection can enable participants to both build a deeper understanding of their roles, practices, identities, but also potentially explore, decolonializing and different alternative practices. These circles were held weekly and focused each week on a different topic. So to encourage storytelling, topics were designed as invitations to speak about specific experiences. For example, this is an example topic here, which starts with a question, "What's tell us?" and asks us, the participant, to recount how they learned about the activity that they did with their client. To encourage reflection on the social and contextual aspects of home care work, we explicitly framed each topic in relation to a different party that the HCW would interact with in the course of a job. So most commonly, these would be patients, such as the example here, but could also be families, doctors and nurses, agency supervisors, and other home care workers. And finally, all topics related to participants' practices as care workers. So topics around practice made visible the less explicit parts of the job and the corresponding skills and values around being an HCW. For example, the topic here enabled participants to highlight some of the interpersonal practices that made patients happy, but might not be canonically recognized as part of their job description. So in summary, we had a typical weekly sharing circle session, lasted about an hour. We started with the beginning of some time for introductions and a review of ground rules, which were intended to emphasize the confidentiality of participants' stories. Participants then spent most of the time discussing and sharing stories around a weekly topic. And at the end of the session, we also gave each participant some time and opportunities to say some concluding words or remarks or say something that they missed saying earlier on. We ran the support program over 8 weeks and recruited 42 participants to the program. Participants were grouped into one of 5 sharing circle panels with no more than 9 participants per circle. And they were led by a pair of home care workers that we had specifically trained to be facilitators. They met at the same time of the week throughout the program in order to kind of build a familiarity with each other. And finally, these were observed by at least one researcher who provided technical support, but really didn't take any leading role in the sessions. They were not recorded in order to encourage participant comfort. So these kind of observations and notes, alongside some follow-up interviews and surveys, were what informed our findings around the experiences of home care workers in this program. So I want to go over just a small subset of the findings that we have. The first is that despite this being sort of the first time for many of our participants in an online support program, HCWs were able to use this space to tell stories about their experiences. The technological environment played a role in creating access to peers and a comfortable space for storytelling. For example, participants were able to join from different physical environments, and at times they were not otherwise able to, such as during lunch breaks and commutes, and were able to meet, participants from different parts of the city that they would otherwise not be able to see. In addition to being convenient, this remote access also gave participants more control over their personal environments and may help them feel more comfortable in their sharing circles. So one participant described feeling more confident speaking, knowing that she was able to turn off her camera, while another described feeling more safe participating from home because she knew that no one was around that could overhear her. Finally, some HCWs used the fact that the video conferencing reached into their homes to share items from the physical environment to aid in their storytelling. For example, in the image here, we see an HCW show us the domino set that she used to play with her patients, while another one shows off the artwork that she received. We also found that the stories participants told were important to building this collective purpose, values, and identity through exploring and reflecting on these shared experiences that they had. By sharing their stories, HCWs expressed their values around care work. As described by the participant quoted here, these included motivations to continue in home care and to balance between competing demands such as work boundaries and financial needs. Throughout these stories, participants connected their practices and experiences and skills to the common values and demonstrated how their practices reflected their values. And finally, participants used their storytelling space to build confidence, pride, and recognition in the role and identity of the home care worker by sharing positive stories, celebrating each other's successes, accomplishments, and the quality of their work. So in addition to reflection on how this value is connected to practice, HCWs obviously also use the groups to improve their skills through information sharing. We found evidence for two different types of information support that I wanted to distinguish. In the first one, HCWs shared stories about workplace experiences to improve practice and enabled participants to access and contribute to a broader body of experiential knowledge. One thing to note here, as many home care skills are tacit, it's difficult to transmit through traditional instruction. And as described by this quote, this reflection and an ideation encouraged in the program enabled HCWs to build a deeper understanding of the thought processes and alternatives presented in different care situations through the experiences of their peers. Secondly, beyond learning healthcare practices, the home care workers shared problems related to the practical aspects of work, collaboratively building understandings of how to resolve different workplace issues, such as problems around receiving workers' compensation, understanding norms around employee rights, and when to contact the supervisor or contact the union. So overall, we found that this sharing circle program enabled HCWs to, excuse me, to use storytelling to address multiple needs, informational, emotional, and political needs, to connect to each other, to address the isolation of home care work, and to explore collective identity and values, and to share knowledge around different potential practices. Beyond HCWs, it's important to remember that I think that it's important to remember that many marginalized worker populations exist in messy intersectional contexts, likely have their own mix of informational, emotional, political support needs and empowerment needs. And so I think flexible pedagogies such as storytelling have relevance for many of these populations. Furthermore, I think there are populations of isolated workers such as HCWs, but also rural workers, domestic laborers, gig economy laborers, who all will increasingly rely on information technologies to access each other and engage in support and political ideation and community building. And so overall, I think there's a lot of room for future work in designing computer-mediated spaces around pedagogies and technological affordances that enable these kind of support and empowerment needs for these marginalized worker populations. So I think that is the entire presentation. Thank you so much, and thanks for sending me questions.
Great, thank you. And finally, we'll hear from Dr. Amara Bensson.
Thanks, Maddie. Let me just share my screen here. All right, so I'm going to be presenting on my research that I'm currently working on with Maddie regarding the association between home health aides voice and job satisfaction. For today, we're just going to focus on the voice and job satisfaction and not burnout. So just a little bit of background, Maddie's prior research has shown that home health aides often feel that communications with their supervisors is often a challenge. And they also note to feel excluded from conversations about patient care, despite being the ones that care for patients daily. This lack of communication tends to lead to feelings of frustration, isolation, and lack of support. Home health aides often also report feeling stranded, particularly when managing patients' clinical changes. Currently, we don't really have much literature evaluating home health aides' perception of their own voice in the healthcare team. And more importantly, we also don't have much literature regarding how their voice in the healthcare team might be related to job satisfaction. And that is our primary question for the study that we did. We used this conceptual framework published by Dr. Sterling and Dr. Avgar, sort of looking at the different components of things that impact worker outcomes and patient outcomes. So for our study, we really considered voice in the care team as a working condition. And we looked at job satisfaction as a worker outcome. So briefly about our study design, this is part of a broader cross-sectional survey aimed to understand home health aide experiences caring for adults with heart failure in New York City. It's conducted in partnership with the 1199 SCIU, as Johnny mentioned earlier, is the largest healthcare union in the United States, representing workers in different healthcare settings. The inclusion criteria for our study, home health aides had to be English or Spanish speaking, employed at a licensed or certified New York City home care agency, and have at least 1 year of job experience. And all surveys were conducted electronically online via computer or phone. So this is the voice measure scale, which has been validated and used before to understand workers' assessment of their voice in the care team. I'll go into the questions a bit more in some later slides, but essentially participants score their responses on a 5-level Likert scale from strongly disagree to strongly agree. For this scale, there was a 6th choice, does not apply to me, and that choice was scored as 0. So total scores for this scale ranged from 5 to 25, with a higher score indicating a higher degree of voice. Our primary outcome, job satisfaction, was measured with this validated work domain satisfaction scale. Again, scored on a 6-level Likert scale, from very strongly disagree to very strongly agree. Scores ranged from 5 to 30, with a higher score indicating higher job satisfaction. So just briefly about our analytic plan, we performed descriptive statistics on the study population. We performed an analysis of voice by participant characteristics. And then we looked at individual voice questions and compare them to mean job satisfaction. And finally, we performed a multivariable linear regression of voice and job satisfaction. So moving into our results, we had 640 home health aides consent to the survey. Ultimately, 413, this number here, completed each line item of both the job satisfaction and voice scale. I will note, so this N right here is our total N. There were 152 home health aides who chose does not apply to me for at least one or more of the voice questions. So in our final analysis, we used the number of 261. This is our table 1, our demographics and home health aid characteristics among our 413 participants. Just calling out a few things, the majority of our population is non-white. They were 97% female, 88% immigrants, and spent an average of 10 years as a home health aide. This is our total population scores for voice and job satisfaction. The voice score, as you recall, the range goes from 5 to 25. And this score is derived from the 261 participants. So their median score was 18. Our mean job satisfaction score was 26.4. Again, as you recall, our work domain satisfaction scale ranged from 5 to 30. And this tracks sort of in line with what we know of job satisfaction sort of nationwide for home health aides. Taking a little bit of a closer look at our characteristics and our study outcomes. So across the top here, we have categorization of low voice and high voice. We made this categorization by a median split. So high voice is categorized as scores between 19 to 25. And you can see here that race and ethnicity was significantly different between low voice and high voice, and then job satisfaction also was statistically associated with high voice. Lastly, this table I know is a little bit busy, so I'll just take a minute to walk through. This is our table 3. So this is the association between the individual voice questions and job satisfaction among all 413 participants. Across the bar at the top here, we have our Likert scale and the does not apply group. We performed P for trend to look at the differences between each response group. Down in the rows beneath, we have each individual voice question with the number of participants who selected each category of the Likert scale. And then we have that group's median job satisfaction score. So how I'm reading this table for question 1, I have a good deal of say about the quality of patient care at my home care agency. 14 participants strongly disagree with this statement, and their median job satisfaction score was 21.5. With regards, sort of looking over here at the P for trend, we did not include the does not apply group in this P for trend, but we did find that as participants agreed with this statement, their job satisfaction scores went up, and this was statistically significant. And this was so across every domain of voice, as you can see from our table here. Finally, we performed multivariable linear regression using the high voice, which again, we categorized as scores from 19 to 25. And we fully adjusted our model for covariates of race and ethnicity and years in the field. So in fully adjusted models, what we found is that high voice is associated with a 1.71 increase in job satisfaction. And this association is statistically significant. So just to briefly summarize the key findings within the domains of voice, higher voice in having a say about the quality of patient care, input about patient care issues, and being listened to by supervisors were all associated with higher job satisfaction. And then again, in both unadjusted and fully adjusted models, higher voice is associated with higher job satisfaction. So just going back again to our conceptual framework, I think there's a number of different implications where our study sort of fits in. So firstly, at the policy level, currently, right now, home health aides aren't included as legally as members of the healthcare team, so they don't have access to patients' medical records. So I think, you know, there's some implications there in terms of including them in the care team. Also, there's, you know, implications for healthcare providers. You know, how do we teach newly minted providers in medical school or PA school or nurse practitioners to include home health aides as part of the medical team? And then particularly at the agency policy and practice level, how do agency policies and practices, you know, be created to increase communication between home health aides and their supervisors? In terms of worker characteristics, we know that home health aides have a number of different vulnerable needs. So how do we as a health system better support and give agency to a population of workers who have vulnerable needs? And then finally, with regards to patient care, how do we sort of change the framework so that patients kind of see home health aides as part of the medical team? I think I'll end there. I don't know how much time I have left, so.
Thank you so much. Okay, so at this point, we've heard from 4 different speakers on a variety of topics related to elevating the role of home care, and I'll now kick it over to Professor Avgar to give us some remarks to sort of tie things together.
Great, thanks so much. And thanks to each of the presenters for their insightful and really complementary studies. A really big thanks also to Dr. Sterling for chairing today's session, and more importantly for her scholarly leadership in the study of home care work and associated outcomes. And I'm really happy for the opportunity to share some very brief thoughts so that we make sure to leave room for questions. One thing that's quite clear across each of the presentations today is that the United States is facing a home care workforce crisis. As our healthcare system looks towards the expansion of home care, home healthcare delivery, our models and arrangements for employing a workforce central to this delivery of care model have to change. As with any significant and consequential crisis, fixing a broken home care delivery system will require novel empirical evidence, insights, and potential interventions from a range of different disciplinary fields and perspectives using a variety of methodological approaches. I'm really excited by today's panel because it is in many ways a model for the type of individual and combined efforts to bring together scholars across medical, technology, and industrial relations domains, employing different methodological designs, all in the service of a deeper and clear understanding of the causes, consequences, and potential solutions for the current state of the home care workforce working conditions. Taken together, the presentations we just heard offer important qualitative and quantitative evidence about the substantial challenges that home care workers face and their invisibility, and as Joy documented, vulnerability within a system that is increasingly built around their labor. Johnny Kallas expands our understanding of the compounded employment conditions challenges of home care workers providing care in rural areas with clear implications for federal and state level policy. Joy Ming and Dr. Anthony Poon's work informs our understanding of specific socio-technical factors and interventions that might help to transform the daily experiences of home care workers, providing clear practical and policy guidance. And Dr. Bensson points to the centrality of voice as an important factor affecting worker outcomes, in this case, job satisfaction, also with clear implications for policymakers and providers. Dr. Benson's presentation, of course, is a really fitting study given the theme of this year's conference, elevating voice and new voices in the workplace and beyond. And I find it really cool that a study from Weill Cornell Medicine fits so nicely within LIRA's annual theme. And forgive me for getting even more excited and saying that it's even more cool that Dr. Bensson uses a patient care voice measure first used by our incoming president-elect, I should say, Paul Clark. Each of these studies points to concrete and actionable measures that can be taken to improve the quality of home care workers' jobs, which, as we all know, of course, are necessary conditions for the delivery of high quality of care. Facing what at times can seem like an insurmountable task of reimagining current home care delivery models, today's presentations demonstrate the power of interdisciplinary research to pave a path forward. And with that, I'll turn it back to you, Dr. Sterling, and maybe we can open it up for questions.
Great, thanks. I think that tied it all together. I'll just, I know there are some questions in the chat, but before we get to those, does anyone have some remarks that they'd like to share or ask? Okay, we can sit on those, think it over, don't be shy. But in the meantime, oh, I see a raised hand. Yes, or Shay.
The name is Or. Thank you for all the speakers. This has been fascinating. A question for Johnny and a question for Joy Ming. Johnny, you mentioned the reimbursement problems with reimbursement policies and the limitation that policies puts on increasing benefits for the employees. Who is the problem? Who's the person or the institution preventing patients and workers from being well compensated? And Joining, my question is about the socio-legal marginalization that you mentioned about immigrant workers. My question is whether their immigrant status is related to that socio-legal marginalization, meaning are they mostly undocumented? Are they on a visa that is contingent on the employer or the company, or is their immigration status affecting their ability to mobilize or to improve conditions?
Thanks, Or, for those questions. I guess I'll just quickly start out, and I don't know if Maddie or Ariel or others may have some better insight on the question of payers into the system, but I think a lot of different federal and state level programs such as Medicaid plays a large role, and those reimbursement rates are often set at sort of different levels of government. I know, for example, there have been a lot of efforts such as Build Back Better, which would have placed a tremendous amount of investment into home care at the federal level, but obviously that's not happening. One of the main points we're trying to make is that these investments need to also account for the problems facing rural home care workers. And that example about transportation and being reimbursed for 30 minutes of transportation time between multiple clients a day, that really adds up. And not all agencies necessarily even provide that same level of transportation pay. That's also a whole other can of worms. So I'm not sure if anyone else wants to speak about the issue of payers, but there just obviously needs to be a lot more investment from both state and federal government into the system.
I have a comment, but maybe we'll hear from Joy first, and then I have a comment on what you just said, John.
Yeah, sure. So I also I don't know so much about like the socio-legal marginalization specifically around immigration status. A lot of what I've seen, or at least spoken to, with the aides is around the marginalization and social cultural status in terms of immigration and what they're facing for the discrimination around that. I'm not super familiar. I'm not sure if others are in terms of whether they're not documented or anything like that, and if that affects kind of their mobilization as well. So.
Well, your question about payers is a really important one and a really good one. I'll just say very briefly to leave time for other questions. You know, in other industries or other settings, when employment relations scholars study poor working conditions, often the tendency is to focus on the employers, in this case, agencies employing home care workers. Healthcare is much more complicated, and it's a much more complicated system. And as Johnny noted, so much of the working conditions are driven by what insurance companies and payers are willing to provide and reimburse work. And so fixing this system, as was seen through these papers, can't just rely on agencies engaging in high road practices. That's important. We need to do that. But it also requires big public policy efforts, as Johnny noted, and as again was illustrated by a lot of these papers today.
Okay, next I'm actually going to go into the chat. There's a comment from, if I pronounce this incorrectly, Joanna Yang to Mara's talk, wondering about the predictors of voice in her study, where she looked at the association between voice and job satisfaction. Maybe if you want to clarify expand upon the question, and then maybe Mara can respond to it.
Yeah, thanks, Mara. So I think I already see your response in the chat, and I'm wondering about what predict voice, because your study look at the association of voice and job satisfaction, but I think there will be a lot of selection issues going on. So I think maybe people will be interested to see who has more voice at the first step. So, but in particular, I think I asked about the organizational practice. So if you see some variation of the organizational practice, so for example, the group characteristics, and you can look at how does those characteristics associated with worker voice, I think that will lead us to some understanding about what kind of policy implication or what kind of recommendation could we make.
Yeah, we didn't look specifically at different organizational practices per se. The focus of our study was really on identifying aides who were employed by a specific agency who work with heart failure patients, but we weren't specifically, and correct me if I'm wrong, Maddie, working at individual organizational practices.
I guess correct. The focus was not at the organizational level, but we did obviously recognizing the importance of the fact that workers are employed in an agency-based model. We did collect information on the agency themselves. So in this study, the aides were employed by 56 unique agencies, and those agencies we then characterized by location and by size. And size seems to be one way to it's sort of like a proxy for staffing, although with aides, it's a nice way to categorize sort of time and funds dedicated to individual workers. So we looked at small, medium, and large agencies, and we did not see any differences actually by organizational size or location. So we looked at a few, didn't see anything, but maybe Mara, we did see some differences by certain worker level characteristics and voice.
Yeah, thank you so much.
Yeah, no problem. So we did, and I don't know if you want me to share my screen again, can pull up, but basically we found really statistical significance with regards to race and ethnicity, mostly with participants who self-identified as non-Hispanic white tended to have higher voice as opposed to other race ethnicity groups.
And I think, one interesting thing is we hypothesized that the number of years you had on the job, we thought that would be associated with degree of voice. So if you were maybe a newly hired worker, we know that turnover rates are particularly high in the first year. We thought, okay, maybe you'd feel like you have not less empowered, lower voice. But we actually did not see a difference in the number of years worked. We also, to the question about immigration, we didn't see a difference. We had a high percentage of workers who were foreign born, as Mara described, and actually did not see a difference either by immigration or sort of as a proxy for acculturation. So it was really race ethnicity that came out. And we're in the process now of collecting some additional measures such as discrimination and other factors that seem to maybe impact whether or not someone feels included on the team or has a voice. And so we hope to do that study in the next year.
Yeah, look forward to see the results.
I personally think one thing that was quite interesting about the findings was just the number of workers who reported that just the questions did not apply to them. So I think that gives you a sense of just sort of the historical marginalization of this workforce, and something that Joy and also Johnny had brought up as well. Before we move, I think we have time for one more question. Is there any comments on the peer support talk, which was Dr. Poon's talk about the intervention-based study? I will say in the medical circles and in the occupational health circles, this work is being moved forward by our team, because since COVID, there's just been an incredible sort of emotional toll that the workforce has gone through. And so there's been a desire for workplace interventions that could actually improve workers' mental and physical health. And so, kudos to Anthony for really spearheading this work, because I think it'll actually serve as really important pilot data for some larger studies that would actually test the impact of these programs on both the workers and the patients for whom they're caring.
I think the time for our session, Maddie, is out, but thanks for chairing.
All right, everyone, I'm going to stop recording. It was great to have you, everyone, and these wonderful presentations and really thoughtful remarks. Let me just stop.